Hi, NephroWorldCup participants. My name is Linda Audeshu, and I'm super excited to review the Saudi Arabia manuscript written by Ms. Al-Qurashi and colleagues. It's entitled The Impact of the Role of Pharmacists in Renal Dosage Adjustment Programs on Renal Drug Dosing Errors, a quasi-experimental study. This study evaluated the impact of an educational intervention for pharmacists in a pre- and post-intervention study design. The authors studied the impact of education on renal drug dosing in adult patients who were admitted to the hospital in the medical or surgical units who had CKD stage 3, defined by a creatinine clearance less than 60 mL per minute, or they had AKI stage 1 or higher. The intervention included educational sessions and written guidance on renal dosage adjustments for inpatient pharmacists. The primary outcome was a change in renal dosing errors pre- and post-educational intervention. The secondary outcomes included description of the pharmacological class of drugs, frequency of pharmacist interventions, proportion of errors by CKD severity. Adjudication of the drug orders for dosing appropriateness was done by a pharmacy resident for patients who had CKD. However, for patients with AKI, 2 independent clinical pharmacists evaluated the appropriateness of the drug doses. The authors estimated they needed a sample size of 344 orders in the pre- and post phase to detect a 50% difference in the primary outcome. That's assuming an event rate of 15% and an alpha of 0.05. The authors employed a convenience sampling of drug orders for a 3-day time period every 2 weeks to achieve the sample size and to achieve variation in the orders that they collected. Overall, 247 patients with 694 orders were included in the final analysis. In the pre-phase, 134 patients were included, and the authors screened 1,372 orders in order to find 348 orders that required a dosage adjustment. In the post phase, 140 patients were included, and they screened 1,400 orders to find 346 orders that required a drug dosage adjustment. If you calculate this represents an event rate of approximately 25% in both the pre- and post phase of the study. The baseline characteristics of the study are summarized in this table. On average, for the entire cohort, the mean age was 71 years, and there appears to be more female cases than male cases, and the mean creatinine clearance was 43 mL per minute. The prevalence of dialysis in the pre- and post phase was approximately 23 to 24%. There were more patients that had AKI in the post phase, 32.1% versus 18.6% in the pre-phase. And more patients had chronic kidney disease in the pre-phase, 81.3% versus 67.8% in the post phase. And now let's take a look at the primary outcome results. Unfortunately, there was no statistically significant change in renal drug dosing adjustments post-intervention. The majority of the orders were in patients who had chronic kidney disease. However, if you look at either acute kidney injury or chronic kidney disease in this table, you can see that there is no statistically significant difference in inappropriate renal dosing. Despite having more patients with acute kidney injury in the post phase, the authors demonstrated a lower rate of inappropriate renal dosing adjustments in the post phase. However, this unfortunately did not reach statistical significance. The rate of inappropriate dosing was higher in chronic kidney disease, but again, not significant. The only significant difference found was that there was an increase in the rate of pharmacist interventions. However, the overall rate of pharmacist interventions is low if you calculate it for the total number of orders. In the post phase, it looks like pharmacists intervened on 20 out of 346 orders. In this figure, we see the most common pharmacological class of drugs was antimicrobial agents, followed by other agents, cardiovascular drugs, and neurological drugs. The renal dosing errors appeared to be increased in the antimicrobial agents post-intervention. And it may be that this was driven by the increased number of patients with AKI in the post phase. Cardiovascular and neurological drugs showed an improvement in renal dosing post-intervention. However, we don't know if these changes were statistically different. In the table below, we see that the odds of inappropriate renal dosing was higher in chronic kidney disease stage 4 and 5 compared to chronic kidney disease stage 3A in both phases. Overall, there was no statistically significant change in renal dosing adjustments post-intervention. The rate of inappropriate dosing went down in patients with AKI, but it went up for patients with CKD. However, it's really important to note that this was not statistically significant. It's unclear whether there is this different level of assessment and complexity for drug dosing in CKD versus AKI, and if this is biasing these findings. The adjudication process was different for AKI versus CKD, and the study had more experienced clinicians adjudicating dosing in AKI with a high level of agreement. Perhaps that was also driving some of the differences that we see in the AKI and CKD cases. Pharmacist intervention increased post-educational intervention, but the number of corrected orders went down. We can only speculate on some of the issues around this finding. Is the missing piece physician education on drug dosing? Was there timely provider communication, and was that a barrier to improving the number of corrected orders? Do pharmacists have a collaborative practice agreement in Saudi Arabia enabling them to make drug dosing changes? The study's strengths include that the authors were able to achieve the intended study sample size. With 694 orders, there was sufficient power to detect a 50% difference in the rate of inappropriate drug dosing. However, when we look at the previous table, in the cases of patients with AKI, the inappropriate drug dosing rate went down by 5.6%. And that represents a 21% change from baseline. So the study was initially powered to find a 50% difference in the primary outcome, and had the study been powered to find a 20% difference in the primary outcome, they likely would have needed a much larger sample size. The authors achieved the pre-specified event rate of 15%. They also demonstrated a high rate of orders, approximately 25%, requiring renal dosing adjustment, highlighting the importance of this problem. The study does have some limitations, and this includes the pre- and post-cohort design, which can introduce bias in studying the impact of the educational intervention. This bias could have been addressed through patient matching. However, the authors did not employ matching for factors such as patient comorbidities, hospital admission diagnosis, the pharmacological class of drug, severity of CKD or AKI, or the etiology of AKI as some examples. Additionally, the authors did not document interventions made by the pharmacist which were not accepted by the physician. So we don't know the rate of agreement between different providers when it comes to renal drug dosing. They did not employ qualitative evaluation of the possible barriers to implementation of renal dosing by a pharmacist. Are there knowledge, workload, time, and communication barriers that need to be addressed? In conclusion, from this study, we can see that renal dosing adjustment is required in 1 out of 4 drug orders. The odds of an inappropriate dose increases with CKD severity. Pharmacist education improves the rate of pharmacist intervention. Numerous studies have been conducted evaluating different types of strategies to improve renal drug dosing. From work we have previously published on clinical decision support in renal dosing, it's evident that multiple strategies are needed that target both physicians and pharmacists using clinical decision support. And this is likely needed to improve the rate of appropriate drug dosing adjustments. Thank you all for listening.